I'm joined as I am each month by Dr. Joe Sirven, the host of Saturday's WJCT program and podcast, What's Health Got to Do with It? He helps break down the latest medical headlines. He takes your calls and questions on any healthcare topic. Welcome, Dr. Joe.
Oh, and it's such a joy to be here.
Happy December.
Happy December holiday time.
Yeah. Did you have a nice Thanksgiving?
I did. How about yourself?
Wonderful. Yeah. Great time.
Just wanted it to last longer.
I know. But here we are back on a Monday. And of course, we hope you had a great holiday too. If you have calls, questions on any healthcare topic, you can reach out on air at 904-549-2937. You can also email First Coast Connect at WJCT.org or go to firstcoastconnect.org and find all the ways that you can connect with us. Dr. Joe, I want to start with some news that could really impact nursing students, both financially and maybe reputationally. This is whether or not nursing qualifies as a, quote, professional degree. Tell us what the Department of Education has been doing here.
Well, the Department of Education basically, for the purposes of student loans and the dollar amount that you can get for student loans for a degree, classifies certain things as professional and some things as not. And I'll just say it this way, stunningly, nursing, as well as physician assistants, physical therapists, audiologists, to pick some healthcare related ones, did not make the cut. There are some things that you try to find a way to say, how do you defend or how do you look at this? I have no words. I'll just say it this way. You cannot run hospitals, clinics, and OR, ICU, ER, the entire healthcare system without nurses. You just can't. And to assume that they're not professional, even if it was for the purposes of a student loan, it boggles my mind.
Well, it's interesting because some of the things that were included, include things like chiropractic medicine and theology, veterinary medicine, but not nursing. And so, I think for a lot of nurses, it is surely could impact them financially if they're in school and they're pursuing a degree and this would apply to certain caps that are available for, recouping some of those costs. But I feel like nursing is often, doesn't get enough respect sort of as it is. Is this something that nurses are concerned will just, diminish their professional reputation or are just taking as kind of an insult?
It's they're taking it as an insult, and they should take it as an insult. This is one of those that needs to get walked back. We have such a we talk about doctor shortages. The nursing shortages, which we haven't talked about a lot, is just as huge.
Yeah.
There is such a demand in all facets of that area. When I was looking at social media on this one, and I saw chief nursing officers left and right talking about this issue, this is that, you have to say something. This is just kind of crossing a line. A lot of people need, as we all talk about the cost of higher education, nursing schools are in that mix. You need loans to help people complete this degree. This degree is needed. From what I can tell, they do very nice living. They could certainly be paid better, but for what they do, this is it's just one of those that I'm just finding myself completely verklempt. I don't have a way of like what was the mindset to reclassify this. This is just one of those areas that I think that just needs to kind of get changed.
Yeah.
Because it's just shooting us in the foot.
Florida in particular has really been working to try to stem this gap that exists in terms of what's needed in the world of nursing. And, there's a lot of schools, including our local schools, that have created fast track degrees. They're trying to get more nursing students in. They're expanding their programming. All of that costs money. And nursing, like a lot of things in medicine, isn't getting any less complicated. It isn't getting easier to do. There's all the time more services that are provided, more complexity to the way that those services are provided. So it is, a difficult thing to master.
I mean, let's look at it this way. If you look at the healthcare system and where we're going, let's take a condition like cancer, for that matter. That type of care is delivered across a team. Yes, there's a doctor on the team, but there is everywhere, left and right, nursing on that team. Let's take
And often have the most patient contact, right?
absolutely. I think about like in an intensive care unit. You define an intensive care unit by the ratio of nurse to patient. So that intensive care is based on the nursing care that is delivered to that patient. That is how you do this. That's why I'm like, this is one of those things that I hope gets adjusted and quickly gets fixed, because this is not going to help any of us. If we're talking about bringing down costs, this is how now you are going to kind of create a situation where you don't get care. This is ridiculous.
Yeah. Well, I think it's definitely something that we'll be watching because this list of degrees that are not classified as professional, I mean, as you said, audiologists, but also architects, accountants, educators, physical therapists, physician assistants, social workers.
It's like I listen to that and I go, these are people that you need on your team. These are elements that you have to have in place for a lot of different healthcare areas.
Yeah. If you'd like to reach us or have a question for Dr. Joe Sirven on any healthcare topic, you can call us at 904-549-2937. You can email First Coast Connect at WJCT.org. And if you would like to remain anonymous with a healthcare question, you certainly can. But Dr. Joe joins us once a month, and now is your time. If you'd like to reach us, we've got a call from Sally in Springfield. Good morning, Sally. Go ahead.
Yes, good morning. Thanks for bringing attention to this. My point is, with no offense to anyone, we shouldn't even be puzzled because the person who is in charge of the Department of Education right now has a background in professional wrestling. And that's just basically my comment.
Yeah, is true. Linda McMahon's background
That's
is
right.
not
That's true.
in education. We
Good
have a
point.
comment also from Jane on Facebook saying Big Ed, as we call the Federal Department of Education, is a tragic, chaotic mess. I apologize to every professional nurse who is injured by this madness.
So true. I'm gonna kind of come clean here. My wife is a nurse. My mother-in-law is a nurse. I am very much. I've learned many pieces of my medical profession from nursing, and when I've had to be in a hospital or seek care, those are who I remember.
Sure.
Sometimes more than the physician itself.
Sure. I think anybody who's had a loved one in the hospital knows that that's also the person that family members most rely on, whether it's to get you a drink, if they can help you out or just, offer some consolation, help to interpret what a doctor is saying. I mean, there's so many services that they provide on just an individual level. Is there anything that you would suggest that people do or could do?
Yeah, this is the time to not be quiet. This is one of those moments that you do have to reach out and either to wherever the Department of Education is or to your local congressperson, just to let them know that you support this and that this needs to change.
Yeah, we've got a call from Peter on the South Side. Good morning, Peter. Go ahead.
Yes, good morning. I might be a little confused. If so, please help me. But a degree is not a professional certification. Nursing is a profession, and you get an RN, but that is not the same as a Bachelor of Science degree that may be a stepping stone. So I'm not quite sure what the implication of this decision is. A nursing certification, a professional certification, is still a registered nurse granted by the appropriate agency in the state of Florida, right?
That is correct. There is nuance when it comes to how you look at the professional degree. There is a BSN, which is the 4-year degree
That's a
for nursing. That's
Bachelor
a
of Science in
bachelor's.
Nursing.
Exactly. There is, if you want to go further, you can go into nursing practitioner. which also you have to have the BSN to go further to complete that particular level degree. Yes, to serve as from a regulatory standpoint, there is an RN or LPN. Those are determined by the state, in this case, state nursing board in that regard. Nonetheless, though, in order to get that particular registration, you have to have some type of education that gets you there. That education falls back into the issue that we were talking about, which is how things are demarcated in terms of loan programs to be able to get whatever work you need to do to obtain that RN, LPN, those type of things.
Yeah, and that's the funding that's possibly going to be restricted. We've got a call from Rachel in Mandarin. Good morning, Rachel. Go ahead.
Hi, thank you for the call. I'm a speech language pathologist and I own a private practice, Brainworks Therapy in Mandarin. And I just want to also call attention that this same lack of professional degree status is affecting speech language pathologists as well. We are the professionals who are working on all aspects of communication and swallowing disorders from birth till end of life, both in the medical system and in the school system, whether it be neonatal, early intervention, disorders with affecting academic progress, whether it's those with neurodegenerative disorders or aphasia or dementia. There's just so many needs within our healthcare and education system that it is completely disheartening what this government is doing to the entire system from top to bottom.
Rachel, thanks so much for your calls and comments. We also have a call from Michelle in Avondale. Go ahead, Michelle.
Hey, good morning to you both. As a nurse of 43 years, it was really disheartening to read the news. I couldn't believe it when I did read it. But my question to you both is, I know a lot of the focus is on funding, but it could be a bargaining chip for businesses, because if we've been deemed unprofessional now, how do we negotiate a viable wage when we're not a profession anymore? Not just for nursing, but just like the speech therapist that just spoke. How do we negotiate? No, these are primarily female roles that have been, for years and years, you were either a teacher or a nurse, or that was your profession. But now, all of that is out the window. What are your thoughts on this?
That's a good question, Michelle. Dr. Joe.
I think that's a fantastic point, Michelle. I mean, I know that in some places, I'm thinking, because I've worked in a few states, nurses are unionized in some locations, and certainly that can play against this. This is another fantastic point you're making in terms of making people know that this is not a minor issue. To the speech language pathologist, that's another group you cannot live with. If someone's had, in my area, stroke, they have to get looked for swallow studies and all the other conditions that were mentioned. This is just something that just cannot stand.
We've got an email from Kelly that sort of moves us into our next topic. She says, please also consider that almost all women who give birth in hospitals are guided through their labor and delivery by nurses. The nurses helped me for my entire delivery. The doctor came in at the very end to deliver the baby. Very true for, I think, a lot of us, and that very often is the kind of care that you get. You do see your doctor very often on rounds, maybe in the late afternoon, and you get kind of an update. But all day, every day, the people that are giving you that hands-on care are nurses. And I do want to talk about pregnancy, because there's a lot of pregnancy medical news lately. So let's start, if we can, with this new questions being raised about the use of weight loss drugs, either before or after pregnancy. We're seeing particularly an increase in women who are beginning to take these medications after they give birth. And a lot of questions people have about whether that is good for the mom, whether that's good for the baby.
Here's the thing, Ann. We also have a lot of questions about the use of these medications. And we're talking about the weight loss drugs like Wegovy, Ozempic, all the other brand names. There is a huge uptick in the use of these weight loss medications postpartum. Now, what we don't know, and here's the thing, is like, what does that do to a woman who is postpartum? There's a lot of hormonal changes. There's a lot of metabolic changes. You're breastfeeding. There are a lot of questions, and the amount of studies that look at this, they're very few to where I would say I don't even know if there are clear guidelines on this issue, but this has become a hot area of usage for these medications.
And so we know that in terms of before pregnancy, there has been an increase also in use of these drugs, and that can be of great benefit to women if they're struggling with obesity or overweight, and they are trying to get in a safer place to deliver because it can be um, less risky for people if they are, if they weigh less, if they're maybe not facing problems that can come with obesity like preeclampsia. And so a lot of doctors are inclined to give these drugs perhaps in leading up to that period. But they can also, when people stop taking them, they can also lead to very rapid weight gain.
That's right. I mean, this is where we get into a lot of nuances. This is not going to be this simple, take this, this will happen, and all will be great. And, I like all those TV ads, the rainbows and all that type of stuff. On one level, before you become pregnant, and if you're overweight, this can be very helpful. What I've heard anecdotally, it actually helps in fertility because women who have who may have been overweight or obese, and they take it and lose weight, and suddenly they can become pregnant. So there's the positive news. Where it gets complicated is that during pregnancy, I hope that you're not taking it because that's a natural time to be gaining weight for you and the
Sure.
baby. After you deliver, that's where it becomes a question. You are set up, the woman is typically set up for breastfeeding. Prolactin, which is one of the hormone that is released in order for you to produce milk. It helps to do two things. Number one, on one element, it helps to kind of burn off calories, but also it can increase your appetite because making milk actually increases your metabolism and
It requires an enormous amount of energy.
exactly,
Yeah.
exactly. And so in that regard, you may find that the appetite kind of increases. But there is also some element that in some women, it can kind of lower, it can help to lessen some of the weight afterwards. What we don't know is exactly how does this drug interact with this hormone specifically. Number two, what about it in breast milk? It's theoretically, it shouldn't cross over, but we don't know. This is the type of questions
Right.
that need to be studied. And I will tell you that when I looked up the studies to kind of see what do we know, the American study on the semaglutide, which is the main ingredient for Wegovy Ozempic, was 8 women that
Oh,
were observed.
yeah.
That's
No,
we're talking millions of people now
that's
taking it.
not a sample size you can rely on.
Exactly. That is where we are in terms of the research in this area.
I mean, the concern obviously is you don't want to be diminishing appetite in a child if there's any chance that could
Exactly.
happen. But also, the
Exactly.
way these drugs work, they can impact, proteins in the body. And a woman needs to sort of have all of her strength to produce breast milk. I mean, it is not a small task to do that.
And this is why I've noticed that the only guidelines I could find is like one in the Canadian group, which are saying we should not be using these drugs at that point. But the data, the numbers, we don't have those studies.
Yeah, and it's going to be a while. Well, we'll have to keep an eye on that. Another thing that I wanted to ask you about is some research that's been done into trying to bring down the rate of C-sections.
Yeah.
So there was a really interesting story just this past week in the New York Times tracking a hospital that had a very high rate of C-sections, 40%, much higher than is recommended. This was Rochester General Hospital in New York. And I mean, a lot of interesting things about how they approached trying to bring that number down. A lot of people thought it's not a number you can bring down. This has to do with the older age of women as they're having the health of women. Things like obesity can contribute to a rise in C-sections. So a lot of people were saying this is just a trend that's irreversible. It's happening and it's just going to continue to happen. But this hospital found that they could actually create some strategies and bring that number way down.
Yeah, this is an interesting element because there was nothing like so new tech or very dramatic about how they did it. For whatever reason, C-section rates in the United States are stubbornly stuck around 32 to 33% of all pregnancies. It should be running, at least per global guidelines, everything, more towards 15, 19%, maybe in 20 is where we should be running. So the US average is just stuck. There's a couple of things. Maybe if people feel that they want to go to C-section anytime there's a sign of trouble. And that's where we get into like if there are complications relating to the women who are delivering. The darker side of that is C-sections make money. It is an operation, it's a procedure, and there is way more reimbursement for C-sections than there are for a traditional delivery. So
Yeah.
we have to put that out on the table too. Somewhere in the middle is the truth. Here's what this hospital did. They just had the uncomfortable conversation with the provider, the OBGYN, the person doing it, to point out, here's your C-section rate. What are we going to do about
Compared to all of the others.
to the others, and can we improve this? And it seemed by doing that little simple thing, it's uncomfortable to kind of approaching a person and telling them, what's going on here? Why is this rate so high? They were able to lower that rate. And that is not too complicated. It wasn't very high tech. It was conversations and kind of like that taking off the transparency so that everyone saw that element. Now, I'm sure that if you're a high risk OB doctor, maybe you're going to have a high C-section rate for obvious reasons, but maybe that isn't the case for every situation.
There are so many things that I thought were interesting about the way that they approached this. And I know that one of the things that they did was to say, we're just going to charge the same.
Right.
If you're have a delivery without medical assistance versus a C-section, we're going to charge the same. And so there was no financial incentive. And that removed, some of the pressures that doctors admitted that they feel. Sometimes, if they've been with someone who's been laboring all
Right.
day and they know if they leave and somebody else sort of gets the sale, if you
Right,
will, right? The
right.
next doctor that comes in. So some of them felt pressure to do a C-section before they would leave for their shift, which shocked me. I just really had never thought about it in those terms. But also trying some more simple interventions, as you said, just sort of acknowledging the rate difference. And then this hospital in particular also would put a little note on the door of a first-time mom, noting that they might need some extra time, that this is going to be a longer labor, presumably because it is a first child, and also prepping moms for this also blew my mind, suggesting that they prepare for a 3-day labor, which nobody wants to prepare for. But they
Oh,
said that
wow.
sometimes women come in with an unrealistic expectation. And so if it is going on past, 12 hours or 15 hours, they might just say, okay, it's time for a C-section, not realizing that that is normal. It doesn't necessarily mean that there's a problem or that they're in trouble. And if they're mentally prepared for that, they might be less inclined to say, let's move to a C-section.
And this opens up a door to another area that could help. And it almost ties in back to our professional thing, to the concept of having advocates with you, whether that is a doula, which is someone who is actually a non-medical professional, yet they are there through the birthing process to serve as both kind of coach, advocate,
Translator.
and a translator for the person while they are in active labor, and maybe they're focused on something else, so that you have someone there in your room, or the use of birth coaching discussions to kind of put this kind of on the table. And these are very useful items that could change that rate.
I do want to just note too, because there's been some recent investigation into the use of fetal monitors, which
Yeah.
is something that is routinely done, strapped to pretty much every woman who's brought in and delivering it in a setting where there's any time to, do that prep work. And they are the top justification for C-sections in healthy pregnancies. And very often the monitors are suggesting distress. Everybody gets worried, and understandably so, but apparently they don't necessarily indicate a need for this medical intervention, this surgical intervention.
So this is one of those areas where really this has to be looked at from a healthcare system standpoint, and how, like, notice how we have picked up on so many variables
Yeah.
that can do everything from a physician shift to the payment to the technology. This almost has to be almost rethought in some ways, because each one of these are contributing to the issue. Again, it's a national issue when you look at just we've been stuck. But my goodness, that hospital, God bless them for figuring out that there are not that difficult or expensive ways that you can kind of get to that answer.
Yeah, and we should say, if we haven't, they dropped the rate from 40 to 25%, so an extraordinary decline. I want to briefly touch on some new research that indicates a similar but different kind of dementia that's called late. Initially, a lot of people thought it was Alzheimer's, but now there's some research showing that it's separate and distinct. What do we know?
So late is a it's more of a recently described type of neurodegenerative condition, a dementia. It is an acronym, and it stands for limbic predominant age-related TDP 43 encephalopathy.
Good job.
I had to write it down because I was like, on live radio, I'm like, I'm going to mess that up. So that is, let's just say late. What's interesting about that, this is a TDP 43 is a protein that seems to get deposited in the limbic system, is where you create short-term memory and emotional regulation. It's something called the hippocampus. It's in our brain, and there is this accumulation and atrophy in that. This type of dementia has two interesting things. Number one, it seems to occur in the older individuals, late 70s, 80s, 90s. In fact, it's very common in that group.
As many as a third.
Exactly. It's huge in that group. The second thing about that is that it is slower than typical Alzheimer's disease, but it seems to be relegated just to short-term memory. While Alzheimer's, you think about, there's other conditions, language, or visual spatial things where you get lost, or you're not planning through tasks. This really is stuck to short-term memory. And the protein is not the amyloid that we've been talking about on our show or this show, where they have those new drugs. It's this TDP43, which is different. And curiously, the same protein that accumulates in frontotemporal dementia, that's the one that Bruce Willis has, or in ALS, which is in a very different condition. The difference between late frontotemporal dementia and ALS is where it accumulates, that it's specific to this area. And that's a new thing.
And this is something that, because it's similar to Alzheimer's, has been tested perhaps without people realizing that this was a separate thing. And so the effectiveness of drugs that have been given for Alzheimer's may have been impacted by the fact that those drugs don't work on this kind of illness.
Exactly. And that brings up the whole issue that we're going to find that there's a grab bag of a lot of different options.
Yeah. And so it's something, obviously, that we're going to continue to watch and see some additional testing on. Dr. Joe Sirven, it's great to have you on the program. Thanks for being here today. Thanks for all your wisdom. And we'll look to see you again next month.
I can't wait. It'll be New Year's. Looking forward to it.